Viewer contributions make local programming possible on WNIN. Become a member of WNIN with your contribution so we can continue to make this programming available. Visit WNIN.org and click on the donate button.
There are several local initiatives that healthcare providers are trying to help in emergency situations. AMR is starting a 911 nurse navigation program. Ascension St. Vincent Stat Flight has installed response buttons in rural hospitals, and Southwestern Behavioral Healthcare now has a mobile crisis unit to respond to mental health needs. Learn more about these programs next on WNIN Newsmakers. Welcome to WNIN Newsmakers. I'm Noah Alatza, Chief Communications Officer for the University of Evansville. Last week, AMR announced a first of its kind in the state program called 911 Nurse Navigation. Here to explain what that is Lee Turpin, Operations Manager for AMR Evansville. Lee, thanks so much for being with us.
Glad to be here.
First, wanted to ask you just about what really is the 911 Nurse Navigation Program. What does it entail?
It is a program that's designed to solve several issues at one time. Essentially, the first of which is the majority of ambulance runs that occur are fairly low acuity. The patients are in need of services, but they may not need immediate life-saving services. And in some places, that's estimated to be as high as 25% of the calls. So what nurse navigation does is intervenes on certain nationally accepted emergency medical dispatch conditions. In other words, once they've interviewed the patient, they code that patient in one of 1,100 different codes. There are certain codes that are keyed in evidence-based wise to be low acuity, and we can take that call and try to put that patient on a pathway to get them the appropriate, cost-effective care for them, to get them more timely care, get them better cost-effective care through using different methods of getting there, such as we can transport them via rideshare to a urgent care or to an emergency room non-emergently. We can shunt them to a teledoc to get them immediate, like let's say their whole need is for a prescription to be refilled. We could get them to a teledoc for that, or even self-care to be utilized for just first aid in general.
So essentially, someone calls 911 and you're able to determine the severity of what that emergency is and kind of point them in the right direction, whether it's this resource or that resource. Correct?
Correct.
Essentially.
Yes.
So are these nurses then that are taking these calls, is this local? Is this a dispatch center somewhere else? Are there hubs around? How does that work?
It is at the moment. It is a national nurse navigation center with nurses licensed in multiple states, including Indiana. We are in the process of bringing up a second national center, be more toward the West Coast. The current one's in Arlington, Texas.
So I know this is the first time something like this program has been introduced in Indiana. You mentioned kind of this national hub, so to speak. Where else has this been implemented? Have you seen the results in perhaps some other states or other areas?
Absolutely. We are currently operating nurse navigation in 30 different communities in 14 states. Most notable, to name a few, would be Washington, D.C., which was one of our flagship initial programs. We're also doing Knoxville, Tennessee, and Wake County, North Carolina, toward the East Coast.
And have you heard positive results from people that from what they've used so far?
Absolutely. It's basically, we're thinking at this point, we have navigated approximately 200,000 calls in these various markets to the savings that are literally in the millions for the patients.
So not only the savings, but what other benefits do you see coming about from this program?
The main thing is it's the right care for the right patient at the right time. And for the ambulance side, it frees up the availability to shorten response times, to assure that the emergency services, when they're needed, get there quicker and have more availability.
I'm curious too, how many runs does AMR, usually do in a year, to share for viewers at home who might not be familiar?
Locally, in Evansville and the portion of Vanderburgh County that we cover, it's approximately 30,000 runs a year. And that does ebb and flow a little bit. That was drastically decreased during COVID by several thousand, and in early years where it gets as high as 33,000. So,
how many of those 30,000 runs then could be perhaps replaced by this alternative program?
We're thinking to start probably somewhere between 1% to 4%, but could be, as the program takes hold, be higher up to 15% of that volume.
Are you getting a lot of 911 calls, hence why this program was created? Are you getting a lot of these 911 calls, though, that could perhaps be directed, like you said, to a nurse? Is it that big of a problem that you've seen to go ahead and implement something like this?
I wouldn't say that it's a problem, so to speak. It's getting the person into the right healthcare pathway to get exactly what they need at a cost that, especially if there's an out-of-pocket cost, they have a deductible or something like that. That's a lot lower using an urgent care than it is an emergency room, if that injury or illness is appropriate for the urgent care.
So let me get this straight. So if you need to call 911 for an emergency, whatever severity extent that might be, from that point, that dispatcher is then able to reroute to the nurse. The Evansville-Vanderburgh County dispatcher is able to reroute to the nurse. Is that kind of how that system would flow?
It would be our dispatcher at our dispatch center. The way it works here locally is when the call comes into 911, if you mention the need for EMS, our dispatchers are put on the line as well, who run the emergency medical dispatch protocols, which is where that code that I was talking about comes up. For most true emergencies, this is not even going to be an option. It won't show up on their screen as an option to shunt or anything. If a patient mentions, for example, motor vehicle accident, difficulty breathing, chest pain, possible stroke, any of those higher level conditions, a diabetic needing sugar, those things are all going to trigger just the standard 911 response.
And so this was already launched last week, effective immediately. You know, would there be a time to perhaps review its effectiveness in the future? Have we thought about the strategy moving forward? If you could shed some light on that.
We are going to be receiving monthly reports that will show, first and foremost, what types of things were shunted and what they were shunted to. But we'll also be tracking, for example, if someone should utilize this system and call 911 again because the care wasn't available or the care was not appropriate or they still feel ill afterwards. We're even going to track the number of things that come back into the 911 system as well.
What's something people at home might not know that AMR does?
That's a very interesting question. I think probably the biggest thing that AMR Evansville does that is different from a lot of different providers is we do a lot of data tracking. We look at a lot of patient outcomes, especially in the arena of cardiac arrest management. And when we're looking at patients who are having an active heart attack who go to the hospital and immediately need to go to a catheterization lab in the hospital, we actually get a lot of national level recognition on our performance in both of those arenas. That's one of the things we hang our hat on, that we've been playing in that data field for 14 years now, and the data is always very impressive to us when it comes back every year.
And very helpful to make informed decisions, I'm sure, in the future. Anything else, Lee, that you want people to know about this program who are watching at home?
Just that it's not a replacement for emergency care. It's for just a specific subset of things where a person could not have to sit, like say in an emergency department waiting room, and then end up with, say, a $700 out-of-pocket bill versus a $42 out-of-pocket bill. So it's just designed to help alleviate the utilization of the ambulance to the utilization of healthcare in general and get the patient to the appropriate care.
Lee Turpin, Operations Manager for AMR Evansville. Thanks for all that you do for the community, and thanks so much for being here.
Thank you.
In January of this year, Ascension St. Vincent began a one-button response for stat flights in 9 rural hospitals around the state. Here to talk about this new program is Diana Kaiser, Air Medical Base Supervisor of Stat Flight 6. Diana, thanks so much for being here.
Thanks for having me.
So first, for viewers at home who don't know, what is Stat Flight?
Stat Flight is an air medical provider. We are a helicopter. We can do either on-scene things, which I think is what most people think of when they think of, air medical. But we also do a lot of inter-facility transfers too.
So when do you get called out? Could you give us an example? Let's say a car crash. I mean, when do you
Sure.
get called out?
Yeah, we go to car crashes. We go anytime EMS feels that a higher level of care might be needed, or simply for patients that need to get to hospitals sooner. There's a lot of research on how quickly a patient gets taken care of or gets to definitive care that increases their survivability rate.
So what is your role with Stat Flight? What do you do on a day-to-day basis?
I'm a flight nurse, first off, and I'm also the Air Medical Base Supervisor. So I still fly, I still get in the aircraft and go on runs and take flights and those kind of things, but I'm also kind of responsible for the staffing and the running of the base as well.
Sure. So walk me through this stat flight button. How does that work, from a very broad perspective?
Okay, yeah. The goal of the button is to get air medical to patients sooner rather than later. So what's going to happen is we've got these out in our rural facilities that are partnered with Ascension, and when they know a patient needs to be transferred out, they push this button. It automatically alerts Stat Flight's dispatch center, which then puts us on a standby for whatever we need to do. So by the time our dispatch gets all of the information, we are already out at the helicopter ready to go. And that alleviates, we're trying to get it to alleviate at least 5 minutes, if not 7 or 8, from our response time.
And walk me through that importance then of speeding up response times in these emergency situations, especially when stat flight is required. Why is that so important?
The phrase of time is muscle or time is tissue. So if it's in trauma patients, car wrecks, and those kind of things, you have approximately an hour before statistics start dropping on their morbidity and mortality. So if we can get them to a hospital within an hour and get them to definitive care, their survivability increases significantly. You also have the issue with patients who are having a heart attack or having a stroke symptoms. Time is muscle and time is tissue. So the longer it takes them to get to treatment, such as taking them to the catheterization lab or taking them to clot retrieval for stroke patients, the quicker they can get there, the more muscle survives or the more tissue survives.
That's fascinating. Do you ever get called out to like someone's house, let's say, who might be having a heart attack? Like where do you draw the line? What kind of locations are you being sent to?
We are always a second responder. We're not allowed to be the first person on a scene or on a medical condition. So normally what happens is these patients call 911 and their local ambulance service comes in and they determine whether the patient needs to be flown or whether they need to be just taken by ambulance for where they go. Now, if EMS determines that they need to get there faster or they need a higher level of care, then they call us and we will meet the ambulance at a designated landing zone or something like that. Yep.
That's very helpful. So back to this button real quick. Have you seen this implemented in the past few months? And if so, could you even share an example of perhaps a situation?
Certainly, yeah. We have seen them in the past few months. We're rolling more and more out. It's a brand new program for us, but it is working very well at getting services to these rural hospitals a little bit faster. The exact numbers haven't quite come in yet, but we're thinking, like I said, that it's taking a good 5 minutes off of our response time, which just gets us to those hospitals a little bit faster.
And as you previously said, every minute is so important, especially in an emergency. Are there any more, perhaps, rural hospitals from our area that could be getting one of these buttons in the near future?
Absolutely. It is our plan to get them out to all of our Ascension providers and the smaller rural hospitals that need somebody there faster than necessarily any other of the bigger city hospitals.
Do you know what the rollout of that looks like, Diana? Is this going to be a months-long, years-long process, or are we just kind of moving forward slowly?
Yes. Right now, we are as a base, we let our corporation or whatever, we let PHI know that this hospital needs a button. They need something to make it easier on them so that they can get quicker service. And so we turn it in, and it's about a 6-week turnaround. So once we tell the company, hey, we want to put an easy button in this whichever hospital, in about 6 weeks, we get it to us, and then we take it out to them, and it works on a cellular service, which is very nice in the hospitals, and it can switch cellular services. So if Verizon goes out, it switches itself to AT&T or T-Mobile or whatever it is. So that stays in service regardless of what is going on around. So.
I'm curious too, where do these patients go if they are on stat flight? Is this Evansville, Indianapolis, Louisville, Nashville, all of these major cities? Where are they going?
All of those. A lot of times we do, the scene flights, and we try to take them back to Evansville. Now, the patients that are in the rural hospitals, we can either go out and take them back to Evansville, which is something we do frequently, or we can take them to anywhere, the most common places we go, where we go to Indianapolis, we go to Louisville, Nashville, we go to St. Louis, and then we also occasionally go to Cincinnati.
Interesting. What kind of area is Stat Flight serving in Southwest Indiana, Southern Illinois, West Kentucky? Is it the tri-state, or what area is it serving?
It is the tri-state. Our Stat Flight 6, serves about a 90-mile radius from Evansville. So that takes us all the way down into Western Kentucky, and then over into Illinois, and then of course up in towards Northern Indiana. We also have 5 other Stat Flight bases in the state of Indiana, and all of our circles cross. So pretty much the entire state is covered by one of our Stat Flight bases.
Is there anything else you would like people at home watching to know about Stat Flight who might not know, or parting message for them at home?
Certainly. We are very dedicated to taking excellent care of our patients. All of our crew members are specialty flight certified. We try very hard to make sure that our patients get where they need to go when they need to get there. Everybody on my crew, everybody at that base is very dedicated in taking care of the patients as they should be taken care of.
Thank you for all of your work. Diana Kaiser, Air Medical Base Supervisor of Stat Flight 6. We appreciate you making time today.
Thank you.
Now we're joined by Terry Gish, Program Operations Manager for Crisis Services at Southwestern Behavioral Health, to talk about the Mobile Crisis Unit, which responds to mental health crises in our community. Terry, thanks so much for being here.
Thanks for having me.
First, for viewers at home who might not be sure, what is the Mobile Crisis Unit?
So it's actually part of a larger span crisis services we have. It begins with our crisis line, 812-422-1100. Anybody can call that. And then we have mobile response as part of that. And then crisis stabilization unit is something that we can offer people for a stay up to 23 hours.
Who would you recommend needs to call that number that you just shared?
Anybody. Anybody who is in crisis, and we don't say if you're going through this, if you're going through that, the person defines the crisis. So if somebody is on the fence about, I don't know whether I should call or not, call. Absolutely.
Okay, that's very important. Walk me through how long this Mobile Crisis Unit has been around. I know, of course, in recent years, perhaps, mental health, the stigma surrounding mental health has become less taboo, so to speak. It's been put into more of the spotlight and more accepted. So how long has this Mobile Crisis Unit been around, and what have you been noticing, perhaps, trends in the past couple of years?
So we started off by taking over the 812-422-1100 crisis line about 4 years ago, and then we branched out into mobile response from there, and then we opened up our crisis stabilization unit.
So relatively new then, only
Yes.
within the past 4 years.
Yes.
What have you been seeing then? I mean, are people using this? Like how often is the Mobile Crisis Unit being deployed?
We get so many calls through the day, and then we're responding in the community every day. And then we've been having folks on the crisis stabilization unit every day. So people can call us. We get some people who they will call and they just need to talk for a few minutes. And it's those kind of folks, before the crisis line was in existence, they were calling 911 and tying up dispatch with those kind of calls. So now dispatch has a button that they could just send the calls directly over to us, and we can speak to the individuals. So we get calls from people who are experiencing depression, people who are experiencing anxiety, people who just need resources, and we take every call.
And I know we had talked to a previous guest about this new program that they're launching, but I'm curious, Terry, too, in your time, have you seen, particularly maybe in the past 5 years, I know you mentioned depression, anxiety. Is there something that sticks out, though, from these calls? Is there something that rises to the top that you're saying, this is an issue in our community, whether that be depression, anxiety? Maybe it's not. I'm just curious if you're seeing a certain trend somewhere.
Depression, anxiety, substance use disorder, and that's one of our favorite utilizations for the crisis stabilization unit, because we get calls from somebody who will say, I've got an appointment to go into treatment tomorrow, but where I'm staying at now, I know if I stay there tonight, I'm going to use. And we can be that safe space for them to help them make it through until they get to treatment.
What is your message for people at home right now watching who might be in a crisis themselves, who might know of a family member or loved one who is? What do you tell them about using your services?
So they can encourage their loved one to call, but also they can call for themselves, because if you're somebody supporting somebody in crisis, then you also need support. And we want to be there for those people too.
How do people, I know you mentioned this people can reach out for assistance. You mentioned the phone number, but how do you guys also work with local law enforcement agencies, kind of a collaborative effort?
We have great law enforcement partnerships especially with the Evansville Police Department, Vanderbilt County Sheriff's Office. So they will call us. Let's say a police officer encounters somebody in the community that's having a crisis. The officer doesn't feel like the person's violent. They don't feel like they need to be arrested. They don't feel like they meet the criteria to be taken to the hospital to be assessed. They call us, we come out. Multiple things can happen. Maybe we speak to the individual and we review some coping techniques with them. They start to feel better. We say, hey, we can give you a ride home. Or we can give them the option to come back to the crisis stabilization unit where they can have some time to get their thoughts together and we can work with them to see what else they need.
I know you mentioned earlier, you guys get a lot of calls, obviously.
Yes.
Do you have a figure of how many you get every year or even every couple of months? Are we talking hundreds? Or are we talking...
Hundreds, absolutely.
Okay.
Hundreds and hundreds of calls every month.
Have you noticed an uptick in that in the recent years? More calls? Is it about the same?
I think we have experienced an uptick just as we get more known. We've passed out crisis line cards to people, and we want to make sure that our name is known even more in Warwick and Posey and Gibson counties also.
I was just going to ask, what does your service area include?
So our service area for responding is those 4 counties, Vanderbilt, Posey, Gibson, and Warwick, but we get calls from all over the place. And one of the most awesome things about our crisis services is anybody can call that crisis line. You don't have to be a Southwestern client. Most of the people who call our crisis line, most of the people who are on our crisis stabilization unit, they're not Southwestern clients. They don't become Southwestern clients. That is not our goal. Our goal is to help the individual in that situation. These are folks, before we established services, they were falling through the cracks. So we want to make sure that we're there for folks regardless of whether they're Southwestern clients, regardless of whether they have the means to pay, because we want to keep people safe.
So what, I know you previously shared the number of the calls. Do you have an example of like maybe a positive outcome? I know you kind of touched on this, but maybe even from a broad perspective, what's a positive outcome? I know you mentioned the coping skills. Do you have something else that comes about from using the Crisis Intervention Center?
We've been able to link people to different resources, to housing resources. We have folks who just show up in this community and they don't know anything that's available here. So we're able to link them to housing opportunities. We've had some great successes with that, getting people into permanent housing, getting people linked up with the provider so they can get restarted on medication. There's so many things.
What is something that people at home might not know that, aside from just the mobile crisis unit, what's something that Southwestern Behavioral Health does that people might not ever think that they do necessarily? Is there something unique?
We do so much, it would be tough to say. The thing I just really want people to know is if they're on the fence, go ahead and call us. And again, regardless of whether you're a Southwestern client, because I say we're not a Southwestern crisis services, we're the community's crisis services.
Anything else? Any last message that you want to let them know? Call if you need to, even if you're on the fence. That's a big takeaway.
Absolutely. If you're questioning, should I call? Go ahead and call. We would love to speak with you.
Terry Gish, thank you so much for your time. We appreciate it.
Thank you for having me.
Thanks to our guest for talking about improvements in local health emergency responses. Next week, we'll talk with newly appointed president of the University of Southern Indiana, Stephen Bridges. I'm Noah Alatza, Chief Communications Officer for the University of Evansville. Thanks for watching WNIN Newsmakers.